Mr. Donohoe?
Yes.
Hi, I'm Dr. Parsons. Would it be alright if I examined you?
Yes, sure.
Thank you. May I have a look at your hands? Can you turn your hands over? Thank you. Okay. May I have a look at your eyes? Can you pull down one eyelid for me, please? Thank you. And now open your mouth wide and stick your tongue to the roof of your mouth. Okay, thank you. May I feel your pulses?
Yeah.
Do you have any pain in your shoulder?
No.
Okay, I'm going to lift your arm. At this point, I would like to check for radiofemoral delay and take the blood pressure.
You don't need to do that.
Please, could you take off your shirt?
Yeah.
Thank you. And rest back for me. And now look over to the left. Do you have any pain in your stomach?
No.
I'm going to press. Okay. Can you put your hands on your hips? Just look at me. And put your arms by your side and roll to your left. Well done, that's fine. Take a deep breath in and out and stop. Breathe normally and you can roll back. And now sit forward. A deep breath in and out and stop. Breathe normally. Deep breath in and out and stop. Breathe normally. When you're ready, hold your breath. And breathe normally. When you're ready, hold your breath. Breathe normally. Take deep breaths in and out through your mouth.
You have 1 minute remaining.
Now lie back. Thank you very much. I've finished my examination.
Okay.
You can get dressed now.
Bye.
Please present your findings.
Mr. Donohoe is an elderly gentleman with signs of aortic stenosis. The physical signs are that he has rate-controlled AF with a low volume pulse. He has a normal JVP and a normal apex. He has a high-pitched and loud ejection systolic murmur which is audible throughout the precordium, but loudest over the aortic area and does radiate to the carotids. He also has a quiet second heart sound. There are no signs of infective endocarditis, of heart failure or of pulmonary hypertension. There are several signs that suggest that Mr. Donohoe's aortic stenosis could be severe. He has a quiet second heart sound, there's a long duration to the murmur, and also he has a low volume pulse, and these all suggest a significant gradient across the valve. However, against this is the fact that he doesn't have a forceful apex beat. I'd like to investigate him further with an ECG and an echocardiogram, which would allow me to check the valve area, the gradient across the valve, and the left ventricular function.
So what would be the differential diagnosis of an ejection systolic murmur?
So my differential diagnosis would obviously include aortic stenosis, but also aortic sclerosis or hyperobstructive cardiomyopathy. If it was a pansystolic murmur, I would also consider mitral regurgitation, although the characters of the murmurs are quite different. So they're heard at different sites, and also I'd expect mitral regurgitation to radiate into the axilla. Aortic stenosis can be heard throughout the precordium, but as I mentioned, it wouldn't radiate to the axilla, instead to the carotids.
So why is this not pulmonary stenosis?
So the site of the murmur would be different. I'd expect to hear pulmonary stenosis loudest over the pulmonary area. I would also expect there to be a right ventricular heave, and perhaps I might expect it in a different demographic of patients, so perhaps a younger patient with pulmonary stenosis.
Any difference between inspiration and expiration?
So I would also expect pulmonary stenosis to be louder on inspiration, whereas aortic stenosis is louder on expiration as a left-sided murmur.
So you perform an ECG and an echocardiogram. The ECG confirms rate-controlled atrial fibrillation, but the echo shows that he's got severe aortic stenosis with a valve area of 0.9 centimetres squared and good LV function. How would you manage this patient?
So the echo has confirmed that Mr. Donohoe has severe aortic stenosis, but we know already that he's symptomatic with breathlessness. Other symptoms that I would want to elicit if I could take a history from him to find out if he'd experienced any angina or syncope, or also if he had any symptoms of heart failure. Any symptom in the context of severe aortic stenosis would prompt referral to the surgeons for consideration of valve replacement.
In the meantime, thinking about the medical management of aortic stenosis, what drug options are you familiar with?
So the mainstay would be beta blockers. There are some medications which is very important to avoid in aortic stenosis, particularly vasodilators, which can increase the gradient across the valve. So these might include ACE inhibitors, nitrates and sildenafil.
What surgical options are you aware of for the management of symptomatic severe aortic stenosis?
So management options would include a mechanical aortic valve, a tissue aortic valve replacement, or a TAVI, which is a transaortic valve intervention. So the advantage of a mechanical aortic valve would be that it's more durable, it will last longer, but it does require lifelong anticoagulation. Obviously for Mr. Donohoe, he's in atrial fibrillation, so this could be a good option for him. A tissue aortic valve does not require lifelong anticoagulation, but is not as durable. Finally, TAVI can be appropriate for those patients who are not fit for surgical intervention.
Candidates need to be familiar with how to differentiate the severity of both stenotic and regurgitant lesions. Specific to this case of severe aortic stenosis, you would be wishing to look for evidence of a slow rising low volume pulse, a narrow pulse pressure, a muted or absent second heart sound, the pitch of the murmur and its length, whether it radiates to the carotids, and any evidence of a left ventricular heave. You may also find evidence of a fourth heart sound in patients with significant left ventricular hypertrophy. By contrast, a patient who has just mild to moderate aortic stenosis may still have an ejection systolic murmur, but where the predominant lesion is that of regurgitation, you may now expect to find a collapsing pulse with a wide pulse pressure and a hollow diastolic murmur heard throughout diastole. The apex beat may be thrusting and displaced.